Good morning. Today we'll be just talking briefly on how can we prevent BPD. So this is a kind of BPD itself is a very big topic, but it is just a highlight on how it can be prevented. What I would just highlight to you is that actually over the last 50 years, uh, we are still talking about BPD, and I don't know, even after my talk, how many more years are we going to talk about it. And as we see, we are actually seeing more and more of smaller babies, and hence the incidence of BPD in these smaller preemies is quite high, going up to 30 to 60% of incidence. And because it's a multifactorial, it's quite difficult to prevent. And whenever you have a BPD, there is an increased mortality, and not only in the neonatal period, but even when they grow bigger, they have a long-term impaired lung functions, and even they suffer from neurodevelopmental outcome. And this leads to a higher resource utilization, a higher cost, and a lot of family separation. Now, if you look at the different diseases over a period of time, like sepsis, late onset sepsis, we have to some extent able to come down from 40 to 20% by so many hand hygiene and all those bundles in our unit. Severe IVH has come down, ROP has come down, PVL to some extent has come down, neck has come down to some extent. But if you see, the BPD is almost actually rising. Um, and this is something which is to be seen. And uh, we could get away from this original BPD, which was looking so bad, and because we could uh, do certain measures, and the classic BPD is just coming down, but the new BPD is coming up, and this is due to the softness, gentleness with which we are doing our antenatal and postnatal care. But the new PPD is evolving because we know we are delivering them much earlier when the lung has not yet developed, and hence we are behind the normal development of the lungs, and we can't do much on that. But still, we will try. Can we really try and prevent the BPD? So, as we said, that it's a multifactorial aeration in the lung development, and antenatal, perinatal factors are also causing concern, like prematurity itself, and if the baby is IUGR, male sex, white, PIH, chorioamnionitis, smoking in the moms, vitamin D deficiencies in the mothers, genetic factors play a role, and we're talking and blaming everything to the genetics now. Postnatal factors like severe RDS, intubating and putting them on invasive ventilation, higher FiO2, early and late onset sepsis, PDA, PPHN, nutritional deficiencies, intrauterine and the extrauterine growth retardation, vitamin A deficiency. Now, the studies have been done, and when we put them all together, the major thing which is contributing to it is the birth weight, severe RDS, PDA, and infection. Of course, the others are also playing a role, but these are major roles which are contributing to the BPD. Now, BPD and the chorioamnionitis has been systematically reviewed and seen to be quite uh, concerning, and so is the urea plasma and BPD. So, odds of having BPD when you have a urea plasma infection is quite high. Now, if you talk about the antenatal steroids, which have helped our babies a lot, and it has reduced our RDS, our mortality, IVH, neck. But unfortunately, if you look at the Cochrane, it was not associated with reduction in the BPD. However, the latest article in BMJ, which was a prospective cohort study and had 81,832 babies, it did show that antenatal corticosteroids does reduce BPD, and especially if the baby is 23 to 24 weaker, then number needed to treat is 6. However, if the baby is bigger, the number needed to treat increases to 778. So, giving antenatal steroids to the mothers is beneficial, and we are talking about giving these antenatal steroids even to the mothers 22, 23 weeks, and they do get benefit when we are given antenatal steroids. Now, another thing which came up with the COIN trial, support trial, CuraPep trial, and AMV trial, Take Care trial, that CPAP when you are giving in the delivery room is quite beneficial and is decreasing our death or BPD. And obviously the ventilation is reduced, and that's why the BPD and death is reduced on the whole. Now, giving surfactant. So, we want to give surfactant not prophylactically, and selective surfactant is to be given. And when you give selective surfactant, the support and the WARN trial combined together has shown to reduce the BPD or death at 36 weeks of gestation. Having said that, we should be giving early surfactant if at all is to be given. So if you give surfactant within 2 hours, it's much more beneficial to reduce the BPD rather than when you delay the giving of surfactant. And that's why to see which baby should be given surfactant, we are European guidelines say any baby who is requiring FiO2 of more than 30%. But the new things which is coming up is that when we are looking at that 30%, we might be delaying giving surfactant to those babies who require it earlier, and hence we are adding lung ultrasound to decide on which babies to be giving surfactant to reduce the BPD. Also, giving a natural surfactant is more helpful to reduce our babies in BPD. So now also the way of surfactant is important. So if you do a surfactant by Ensure or Lisa and not ventilating them further, has a beneficial effect on reduction of BPD and need of oxygen at 28 days. And this is very important. Also, there was a systematic review on Lisa or MIST to see if it, when you use a Lisa or MIST, does it reduce a BPD and mechanical ventilation. So systematic review in 2020 showed that there was a significant decrease in BPD rates in the thin catheter group, and the RR was 0.47 and confidence interval was 0.3 to 0.66, which is quite significant. This was in RCTs. Also in the observational studies, it was seen to be quite effective, and hence we can say that Lisa and MIST is good if you have a good learning and your team is quite okay to give Lisa and MIST and have expertise to do that. Then all the babies you cannot get away from ventilation. Some of the babies you might need to ventilate. And when you need to ventilate these babies, you should know which ventilation mode to be used. And so volume guarantee should be used in all these small babies. And volume guarantee will definitely reduce the volutrauma and hence the BPD. And if you look at the duration of mechanical ventilation was much reduced when you used volume guarantee ventilation, and this was a published paper in 2013 archives, and we all know that we should be putting our babies on a volume guarantee, and that's what we do in our unit. Then high frequency ventilation is coming up as a big modality, and some of the people in some of the like Iowa group, when they were talking about saving these small babies 20 to 23 weaker, they were directly putting on high frequency ventilation. However, If you look at the trials, it did not show that high frequency ventilation will reduce the BPD or death if you use it as a primary mode as compared to the CMV, though it is going in favor of high frequency ventilation. And there was another meta-analysis which compared conventional versus high frequency ventilation, and they also did not find a significant difference in the incidence of BPD. And what it what do we do is that we keep our threshold quite low. We start with a conventional mode of ventilation. We start volume guarantee, SIPPV mode, assess control. And in case the baby doesn't improve, and if your PIP is more than 22, we put the babies on a high frequency ventilation. So we don't wait for 14 MAP. We go quite we have a lower threshold because we don't want our babies' lungs to be damaged, and after that, giving them some extra support. Then the lower versus higher oxygen target, we all know that if you give a lower oxygen target, it favors BPD. If you go for a higher oxygen target, it will cause more BPD. However, if you go too low, you may go for a baby with a bad neurodevelopmental outcome, cerebral palsy might increase, and hence we are keeping our FiO2 between 90 to 94, not going lower than that. As early we were going 85, 88, that is not to be done. And with 90 to 94 also, you will have a better effect on the BPD, but don't go more than 94. Then caffeine. CAP trial, everyone knows, and we all know that if you give caffeine, numbers were around 1,000 in each group, and they found that if you gave caffeine, the BPD was 36% as compared to 46% when you don't give caffeine, and hence it's a very, very good modality to reduce the caffeine. And we are coming to the trials where we are talking about giving caffeine quite early on. So we were talking of giving caffeine within 12 hours, 24 hours, and then came that we should be giving caffeine within some 2 hours or so. And if this trial is to be seen, it is a descriptive clinical outcome. Early caffeine 4,528 versus routine caffeine were looked into, and they did not find much difference in the outcome. So, but there are more RCTs going on, and we might be able to get a better answer on that. However, we in our unit, we are starting caffeine within first 2-3 hours. So we have kept our quality initiative where we are looking at that how early we are putting the baby on the CPAP, how early we are giving surfactant if required, and how early we are giving caffeine, and how early we are starting our babies on TPN. So vitamin A. Vitamin A, if you see the systematic review which was published and had shown that vitamin A reduces the BPD. However, if you know that we have to give to these small babies 2 injections in a week, and there are no muscles, and it is not IV, it is intramuscular, it's quite painful. And if you look at the how much is the effect. So this is a very nice slide which shows that the good effect is quite less, and hence to if we were here definitely we would have gone for it, but this is very, very trivial good effect, and hence we do not prefer giving injectable vitamin A. Oral vitamin A studies are still inconclusive, so we'll wait for more studies to come in. Then PDA treatment to prevent BPD, it's different. It's a debate. I think it will not end whom to treat and whom not to treat. When should you treat the PDA? And this is itself is a big topic to discuss. But what I would say here is that there are certain trials which are come up which have shown that, and there were recent trial. This was Sung et al. In 2018, showed that non-intervention in 23 to 26 weeker was associated with less BPD than doing intervention and treating the PDA. And then a European population-based cohort study, EPIC, which had 700 babies, 19 regions in 11 European countries. And they also found that infants treated with PDA were at higher risk of BPD or death in all the regions. So this gives us that we should not be very, very liberal in treating these PDAs, but at the same time, we should not leave them because it may lead to neck or renal failure or BPD by itself. So we should be doing our ecos routinely, and even hemodynamically significant PDAs are to be seen. And if we really have a hemodynamically significant PDA, then we can treat them. And it's said that if you don't treat by 2 to 3 days, it is not going to increase the risk of BPD. But if you delay the treatment for more than 7 days, it might risk death or BPD in these babies, where it is very, very significant duct hemodynamically and babies on a mechanical ventilation. So because therapy itself may be independently increasing the risk of BPD, we should not forget that. Baby Oscar trial results are awaited when we will be able to talk about it more openly, and maybe more, maybe not. So let's wait for that. Then the postnatal steroids, there are two ways to give these postnatal steroids. Early steroid treatment, when we are giving at before or at 7 days, and there are 30 studies enrolling 3,750 babies, and day steroid treatment after 7 days, 21 studies enrolling 1,424 babies. And we all know that if you give early steroids, it is going to cause more of less BPD, but more of CP and neurodevelopmental outcome will be bad. So whom to choose is very, very important. It is more important than treating a PDA, whom to choose. And this is a very nice cartoon where you can see that if you are treating with steroids, it's going to increase the CP. And if you're treating with steroids, it is reducing the BPD. So we have to actually draw a kind of a balance where which babies to be treated. So we know that we have an NICHD um, risk calculator, and that risk calculator can be used in the unit where you can calculate the risk, and that will give you the risk depending on if the baby is mechanically ventilated. So if the baby is mechanically ventilated at 7 days or more, 7 to 10 days, then you can put the baby in the risk calculator and see if the risk is coming more than 65%, you will give the baby steroid. But if the risk is coming less than 35%, you will not give steroids to these babies. So this risk calculation is very, very important to give steroids or not to give steroids. Then inhaled nitric oxide use in a preterm babies to reduce the BPD is not recommended. However, if we have a baby who is showing PPHN, whose pulmonary pressures are higher because of the chronically problems, and then if you give a nitric oxide, these babies would be benefited. As I said, we should be talking of nutrition to our baby. So we should be trying to give TPN early. These babies with BPD require more calories, more protein, and that should be taken care of. But before that, if we are giving our babies mother's own milk, then and from the beginning, it has shown in a systematic review and meta-analysis that it reduces the BPD. And this is a beautiful reduction, which is, I would say that we should be giving all our babies mother's own milk, and so we should have a breast pump given to the mothers right at the day one. Antenatally, we should be talking to the mothers, and we should have a real emphasis on mother's own milk. Vitamin D, it is an anti-inflammatory, and also it mediates a key alveolar signaling pathway promoting the perinatal lung maturation, and hence vitamin D should be started as early as possible. And even vitamin D should be seen in moms, that they should not be vitamin D deficient to prevent BPD on our babies. Then new kids in the town is stem cells, phosphodiesterase inhibitors, and perioxysmal proliferative activator receptor agonist. And These are the ones which are still under the trial, and we have to be looking it into it. And with this, I would end my topic on prevention of BPD, and would be open for questions.